And I have a professional and personal interest in looking at adherence to immunosuppressants post-transplant. From a professional perspective, as a health psychologist, I think that adhering to medications can often be a very challenging behavior. So people are asked to change their behavior and take often very nasty medications to improve health outcomes. And I think non-adherence is so individual to the person. So everybody doesn't take medications for very unique reasons, but yet we have very generic, broad spectrum interventions to try and improve that. So I'm always interested in how we can target those individual reasons in very broad spectrum interventions. And from a personal perspective, I know a lot about kidney transplants and renal failure, in that my mum, Marie, had kidney failure for all of my life. She died earlier this year, but she had 2 kidney transplants in the 90s, before there were apps and websites and so on to help people track their adherence. She spent 7 years on peritoneal dialysis and a total of 18 years on hemodialysis. So we knew the ins and outs of kidney failure. And I remember as a child syringing up the cyclosporin out of the bottle and putting it into water or milk or orange juice or whatever took the nasty taste away. And I think importantly, I really seen firsthand the side effects of those medications. So for a woman in her 30s to have, you know, swollen ankles, fluid retention, unwanted hair growth, trouble walking, being in hospital a lot with infections, I really saw the distress associated with taking these medications, even though they were crucial for survival. And meeting lots of transplant recipients over the years, you know, I've come to understand why people may not take them as they should. I meant to say I'm also an executive director for the Irish Kidney Association, which is the charity in Ireland responsible for organ donation, so all organs, and also patient support for people with kidney failure. So I do meet a lot of organ recipients in my personal life. So that's, I suppose, why I was motivated to fill this research gap in terms of what works to help people improve their adherence to immunosuppressants after such a huge life event as an organ transplant. I suppose just to point out, I initially contacted the Cochrane Kidney and Transplant Group to do this review in kidney transplants, and they came back to me and pointed out rightly that the immunosuppressant regimen is pretty much the same across all organ transplants. So we did widen it out to all organ transplant groups. And with that in mind, I invited experts from the organ transplant services in Ireland to be part of this service or this review. So one person per organ, you might say. And we had a methodological expert from the University of Memphis to help us with methodological assessment, and then some statistical colleagues from the Royal College of Surgeons. That's the protocol at the bottom of the slide. There were some protocol deviations, which I will talk you through in this presentation. So let's start and look at adherence. What's the issue post-transplant? So we know that adherence to immunosuppressive therapy is central to preventing organ loss. It's the crucial core part of treatment post-transplant. And we know that the strategies are fairly similar across all solid organ transplant types. But I think importantly, the treatment is lifelong. So there's no coming off these medications, whether you like it or not, if you want to sustain your organ and stay well. So it's often assumed that people are motivated to keep taking these medications, but yet the rates of non-adherence are a lot higher than we would think. So that questions this assumption that we have as healthcare professionals. So different meta-analyses have shown that there's quite a high rate of non-adherence post-transplant. On average, across all of the organs, it's 22.6% of patients are non-adherent. Rates do vary by organ transplant type. So it's highest in kidney transplant recipients. And I think the reason for that is if you have a kidney transplant and it fails, there's a plan B in that you can go back on dialysis. And I've often heard people tell me that they were so unwell when they were transplanted that going back on dialysis was almost a relief because they felt better. Whereas in other organ transplants like heart, liver, lung, rates are a little bit lower because there is no plan B. You need your transplant to work. So the lowest non-adherence rates are in liver transplants. Rates of non-adherence do vary by age. Pediatric population is hard to get data on it, but adolescents, the rates of non-adherence would be quite high in an adolescent group. So I suppose my question is, or the question that led to this review was, if it's so important, why don't people take their pills? And I suppose from my perspective, adherence is such a complex behavior, and it's really important to figure out what works and for whom. That was really the motivation behind this review. And I think when you're studying adherence, it's important to understand the difference between non-intentional adherence and intentional adherence. So we're all familiar with intentional non-adherence, where we forget to take our pills, we don't understand what we're supposed to do, we take the wrong dose, and so on. So as a healthcare person, you can understand this, you can see why people make mistakes, and we can give proper education to help people alter those mistakes. So non-intentional adherence is fairly easy and straightforward to understand. Intentional non-adherence can be more difficult, because this is where somebody chooses to not take their medication at all, or to alter the dosage, or to stop taking it for a while, or to play around with it in ways that it was not prescribed. And this can be harder to understand as a healthcare professional, because you know the benefits of these medications, so it's hard to empathize with the reasons why people may not take them as prescribed. So given the complexity of barriers to adherence, strategies to improve adherence must account for the multidimensionality of that. So capturing non-intentional non-adherence and intentional non-adherence. So a simple word is actually quite complex, or a simple behavior is actually far more complex when you actually look at it. So the point of this review was to assess the effectiveness of interventions that are designed to improve adherence to immunosuppressant therapies following a solid organ transplant. And to point out, we only focused on just immunosuppressant medications. I know people post-transplant are on a rainbow of medications, but this one is so central to keeping the transplant alive. We just focused solely on this one. So it was in all solid organ transplants, so heart, lung, liver, kidney, pancreas. Our inclusion criteria were very broad, so it had to be a randomized controlled trial, but there was really no limitations after that. We had adults and pediatric populations, and we also included first and subsequent transplants. So it was a very broad spectrum search of the literature. I won't bore you with the details of the search string and search strategies. When the Cochrane is published, there will be more details, but safe to say, Cochrane are extremely pedantic, and we had an information specialist from the Cochrane and Kidney Transplant Group who guided us through every step of the search, and who is a wizard at the search. So it was very, very thorough, comprehensive, and very rigorous, and took a long time, I would say that. I think one of the hardest parts of this review was to settle on the most accurate way to measure non-adherence. And initially we had we were grouping outcomes by type of intervention, and then a peer reviewer said, look, that doesn't make sense, this isn't the gold standard. So we came to this other method for using a framework for conceptualizing non-adherence, and we do believe it to be the best one. So the ABC taxonomy for medication adherence is what's used as the gold standard now for looking at adherence. And when I say adherence, I mean adherence as a behavior. So the actual act of taking a medication, not looking at surrogate outcomes and so on. So the actual behavior of adherence. So when looking at that behavior, there's two parts. There's the initiation of taking the medication, so actually starting the prescription. And then there's the implementation, so it's carrying out the behavior long term. And that phase has 5 parts. The first is taking. So taking adherence, actually taking what you're prescribed. The second part is dosing. Do you take the correct dose on the correct day, so on. Timing, as we know in immunosuppressants, is really, really important. So are medications taken on time? Are there any drug holidays? So if people decide they're doing well, do they stop for a few days? If they don't feel well, do they stop? Do they have any drug holidays from the prescribed regimen? And then the last one doesn't really, I suppose, fit for immunosuppressant therapy, but it's persistence. So this, if you think of broad spectrum, is when the prescription is done or when the regimen is over. So say if we think of antibiotics, persistence would be, did a person take the entire course and stop when they were supposed to? But in a transplant population, there is no end. The persistence has to keep happening until graft failure or mortality, you know. So persistence didn't really count in this instance. And the gold standard of measuring these different domains of adherence should be through electronic monitoring, so literally real-time information on adhering to the medication. And if that's not possible, looking at pharmacy reconciliation data. So did people actually pick up their medication or their prescriptions, and did they have enough medication to cover them for the time period that they were prescribed? So that taps into the taking and I suppose the drug holidays part of this taxonomy, but it doesn't cover all 5, which is why electronic monitoring data is the gold standard really. We did also look at the surrogate markers of adherence. So I suppose the byproduct of doing that behavior properly. And there was subjective and objective surrogate measures. So we did look at self-reported adherence in terms of different questionnaires that are used in research to get people to self-report their behavior. But people can often, I suppose, massage the truth when they take those questionnaires. So I always take self-report with a pinch of salt. Unfortunately, I've been burned in the past. In terms of clinical parameters, again, these are indirect effects of adherence or non-adherence, but they don't directly measure the behavior. And importantly, they can be affected by a range of different events in terms of other comorbidities, infections, all of those types of things. It's not a direct consequence of the behavior, but they give us a sense of whether somebody is broadly taking their medication. So things like immunosuppressant trough drug concentration levels, acute episodes of organ rejection, graft failure, death, health service use, and in the reviews, in the studies we looked at, rehospitalizations was the only one that was properly measured. We also looked at health-related quality of life, but again, this was kind of poorly measured, so we only really summarized that. So that's what we wanted to do, and that was our methods. So what did we actually find? And again, I'm kind of flying through this and just giving you the broad points, but I can give you more detail on the methodology if you would like that after this. So we had 40 studies, which for any of you who've done a Cochrane review, that's quite a lot. It's a lot of data to trawl through. We had 39 RCTs and 1 sequential control group design. So we had nearly 4,000 participants across those studies. 5% of them were a pediatric population, mainly adolescents. The majority of the trials were interventions in kidney transplant populations, which wasn't surprising. 6 in lung, 5 in liver, 4 in heart, 3 kidney pancreas and 2 kidney liver. So quite a variety within that. Then looking at the types of interventions, and I will come back to this, but 27 were what we call multi-component interventions, so where there was more than one thing happening in that intervention. So for example, a single component intervention was a dose simplification intervention, where a person went from taking mainly tacrolimus twice a day to once a day. So that was a one behavior change technique. Most of the interventions had more than one, so it could be dose simplification plus an app to measure it, or dose simplification plus psychoeducation. So there was 2 things happening there. The trials were spread all over the world. There was quite a broad mix. None in Canada, which we hope to change, or I was disappointed to see. Maybe they're all adherent in Canada, we don't know. The interventions varied in terms of how long patients got them. It varied from 8 weeks to up to a year. And I think it's important to flag that the length of follow-up was quite short. So it does say 10 years on the slide, but only 1 study followed people up for 10 years. All the rest of them were about 12 months. So if you think of the impact of interventions long-term on medication adherence, so what happens in 5 years' time, we can't discern that, unfortunately, from the type of data we have here. When you do a Cochrane review, one of the core parts of it is to assess the quality of the studies. So if we're basing clinical clinical management from this evidence. What's the quality of that evidence? So a core of Cochrane is to assess the risk of bias, and it's quite a big part of the review. And what this graph shows you, or this figure shows you, is that the quality was quite low. So where you see red, that means there was a high risk of bias, and yellow, it's unclear or not great, and then green is good. So in terms of the different domains of bias, a lot of them were compromised, but that's not to say they weren't good trials. When you're looking at real life interventions with people, it's just I suppose, a byproduct of the type of intervention that there will be low or high risk of bias. It's just not surprising given the nature of these type of interventions. So for example, a patient is aware if they're getting above and beyond usual care. So if you're being given a pill box and a smartphone and you're being given 6 counselling sessions, you know that's above the norm of what you would normally be getting post-transplant. So it's very hard to blind participants to that. It's also very hard to blind outcome assessment. So if people are self-reporting, they're giving their own outcomes. Oftentimes the team was so small that they couldn't get independent outcome assessors because that costs more money. So just the nature of the studies meant that it was difficult to really lower the risk of bias in all these areas. I think I've learned a lot about reporting trials from doing quality assessment, because in some cases, you know, we I suppose hypothesized that there was, you know, appropriate randomization techniques, for example, but because it wasn't specified in the paper, we couldn't mark that as low risk of bias. So I think it's a real lesson in how you have to really report every step of your methods in order to rate your quality of the study as high. So what did we actually find when we looked at those outcomes? So when I talked about the 2 parts of the ABC taxonomy was initiation and implementation, no study actually documented initiation. So it was just, I suppose, presumed that everybody started taking the medication. But because it wasn't documented in the trials, we couldn't actually analyze that. So we actually only ended up analysing the implementation piece, so the actual behaviour part of taking the medication. So the first one was taking, so if people were actually taking the medication. And what we found was there was 7 interventions that recorded taking adherence. Only 4 of them were meta-analysable, and from those 4 studies we did find an effect. So there was some evidence. There was a small effect for the fact that the interventions were successful in improving taking adherence amongst the population. So people were more likely to take their medication if they were in the intervention group. But I suppose it's important to note that the type of interventions varied quite significantly. So some within these 4 studies, some were dose simplification interventions, some were multi-components, so there were educational, psychoeducational, some were apps. So there was variance here, but I suppose the key message is there was some evidence to say they worked, and this was positive to see. Then the next step in that implementation is, so you're taking it, are you taking the right dose? 9 studies looked at this in our review, and 8 were meta-analysable, so they had data on dosing adherence, so the proportion of people who were achieving the right dose. And what we found was, again, there was evidence to suggest that the interventions did improve dosing adherence, so it improved people's ability to take the correct dose of the medication. Again, the types of interventions were quite varied. So in addition to the ones in the previous slide, a couple in this meta-analysis were quite psychological, so cognitive behavioural therapy sessions plus motivational interviewing, apps with different types of, with a number of behaviour change techniques in it, and dose simplification plus an app. So, but regardless of the type of intervention, overall there was an effect in terms of the fact that they were effective in reducing non-adherence. And I suppose this is where the evidence or the good news stops in a way, in that for timing adherence, we didn't find any evidence to support the impactfulness of interventions to change adherence around timing. So again, the interventions were very varied, but there wasn't enough evidence to say that those interventions help people to take their medications at the right time. Similarly, for drug holidays, we didn't have enough evidence to show that there was an intervention effect for drug holidays. And again, you can see there were only 3 studies that were meta-analyzable. So we were just at the limit of the amount of participants that you can actually have to actually run a meta-analysis. So there's a real, I suppose, paucity in the data that we were able to look at in this. So those was the actual behavior of adherence, of the adherence behavior. Now I'm going to take you through the secondary outcomes. So those are those surrogate markers of non-adherence. So if somebody's not adherent, how does that play out in terms of their clinical outcomes? So the first one we looked at was self-reported adherence. And the first thing to say is that the measures used or I suppose the questionnaires used to assess adherence varied quite widely. But what this meta-analysis looked at was the proportion of people classified as adherent, regardless of the measure they took. So it was a standardized a meta-analysis for this, and we found no effect. So there was no effect of the intervention on self-reported adherence. But you can see there was a number of different measures, and I suppose just as a side point to note, if you're ever thinking of using the Morisky medication adherence scale, don't. I used it 5 or 6 years ago for a different study in asthma, and I received a legal letter saying I was in breach of copyright and was, I suppose, billed for a couple of €1,000 at the time, which we didn't pay. If you Google Morisky medication adherence scale, you would see there's a lot of articles around the scientific integrity of the developers. It's quite an interesting thing if you are interested in that, looking up that. So don't use it is what that would be my recommendation. But the point is, again, there was no effective interventions on self-reported adherence. An outcome that a lot of the clinical team on this review were very interested in was, were there effective interventions on keeping trough concentration levels at target? And the short answer is no, we didn't find evidence for the effective interventions for that. But again, so many different things can affect the levels of the medication in a person's blood. So it can vary so wildly that it's very hard to pinpoint the effect of an intervention. A person may be very adherent, but other things can be happening for them that can throw this off balance. So I wasn't really surprised to see no effect here. And again, we had very few studies, and there was also wide variation in how target was defined. So no 2 studies used the same targets to define adherence. But despite this, in this meta-analysis, it was, did the person actually reach target? So we standardized that again in the analysis, but there was no effect. The next few analyses I'm presenting, I suppose that the point is that within the year follow-up, so most studies only had a year follow-up at best, events like graft rejection, death and so on, they were very uncommon. It was a very short follow-up window of 12 months. So because there were so few events, the studies were underpowered to actually detect the effect of an intervention. So I'm just showing you the evidence here, but again, I think you would need a lot longer time span or follow-up time point and a lot more events to actually be able to detect any evidence to show that the interventions had an impact on these secondary outcomes. So there was no effect for acute graft rejection, even though quite a number of studies measured it. There was no effect for decreasing the number of graft loss, but you can see there the number of events was very low. There was no effect observed for death, but again, positively, there were very few deaths within the year follow-up for most of the studies. And interestingly, the hospital readmission rate was higher in the control group, and it almost reached statistical significance. So that indicated that perhaps there is approaching evidence that the interventions kept people out of hospital. But again, we didn't have enough evidence to actually say that with some certainty. So that's what we found in the review of those 40 studies where we I suppose, summarize them all, but what does it actually mean from a clinical perspective? So what we found was, based on low quality evidence, the evidence suggests that the interventions do work in terms of taking and dosing adherence to immunosuppressants. So when we think of that adherence behavior, the interventions can help people to take them and to take the right dose. And this may support clinical interventions in terms of the correct implementation of a immunosuppressant medication regimen. But again, the evidence is quite low quality based on the risk of bias parameters I talked about during the presentation. There was also no effect or no evidence of effect for timing and drug holidays. And if you think of immunosuppressants, timing is quite key in terms of if it's a twice daily regimen. So we didn't have enough data to look at I suppose, assess that correctly or effectively. There was also no evidence for the effect on secondary outcomes that are those surrogate clinical markers of non-adherence. But again, as I said, the events were quite low, and things like target trough concentration levels, there was quite a bit of heterogeneity in measurement. And I'll come back to measurement in a moment. And I think this is a key question, because there was such a variation between the types of interventions. And although we had nearly 4,000 participants, the sample sizes within the studies were quite small. We didn't have enough intervention to say, well, which type of intervention works best? So initially, we had tried to group interventions, to put all of the dose simplification interventions together and see were they effective versus all the psychoeducational interventions. Were they better than dose simplification? But we didn't have enough of those studies, and it was also too varied. So what would we do with an intervention that was multi-component, that was a dose simplification but a technological intervention with an app? So that's why the ABC framework for looking just at the behaviour and not taking into account the intervention was the best approach at this stage of the type of evidence we have available. I suppose a positive point that we didn't see any harms of intervention participation. So these types of interventions aren't harmful, which I think is a really good point to note, particularly if we're trying to tweak them and make them work better. At least we know they're not harmful to people, or there was no adverse events as a result of being in the intervention group, which was very positive. In terms of, for those of you in clinical practice, what does this study mean to you, or how might this change your practice? And I think it's important to come back to, why do we study adherence? And adherence is the single most important modifiable factor that affects a person's treatment outcome with a chronic disease. It's the one behavior that you can change, that the patient themselves can change. So that's why it's the most important modifiable factor. So in this population, in a post-transplant population, although we did observe some effects on taking and dosing adherence, the quality of evidence at the moment is just not strong enough for us to, I suppose, give clinical recommendations to people working with post-transplant patients. And interestingly, like I said, there was only largely a 12-month follow-up. So there's no strategies from this review to say what works to maintain those levels of adherence. So we only have data up to 12 months. What happens in 3 years or 5 years? Do those effects we've seen on taking and dosing adherence, do they stay sustained over time? We can't answer that question in this review. But the last point there is, when we did the review, we identified 28 ongoing studies, which firstly says that this is seen as a very important priority in post-transplant management, because that's quite a lot of trials to have ongoing. And I suppose the good news is, or the bad news for me, is that we have to update this in 2 years' time. So stay tuned for the update of this review. But I think that's also important to show that, we will have more evidence in a couple of years, and we will be able to say with more certainty, can we make recommendations to impact on people's practice in this population. So hopefully those studies will be more methodologically rigorous, will have a lower risk of bias, and we will have stronger evidence to make recommendations, or to have more confidence in the findings. And then looking at research. So how can we take this forward from a research perspective? And I suppose this is something that I'd be very interested in your thoughts on in terms of how do we accurately measure adherence? So what the literature would say is that electronic monitoring is the way to go. This is the gold standard when we talk about monitoring a person's adherence to medication. So obviously it has very obvious strengths in that it allows for intensive reporting of a person's medication taking behavior. It looks at each phase of that on a day-to-day basis. So you're taking, dosage, timing, drug holidays, persistent. All of those are measurable through electronic monitoring. However, there's quite a big limitation. Just because you open the pill box doesn't mean you swallow it. You could give it to your dog, or it could drop on the floor, or you could put it all in the bin, but the data is telling the assessor that you took the medication. Also, technology fails all of the time, and if the device breaks, then what do you do? How do you record it? So I suppose multi-measurement approaches have been found to have the highest sensitivity and specificity. So in terms of triangulating how you would measure adherence, so self-report, electronic or an assay, so those clinical parameters, and clinician report are stronger than just electronic monitoring alone. But if you think of the cost of that, both the financial cost and the time cost, so to triangulate all those types of measurement, that's very costly. And do we actually have time to do that in reality, in the real world? And the answer is really no, I suppose, unless it's funded through a research channel. I think one thing to keep in mind with this type of research is that clear operationalization of adherence measurement is so critical in terms of transparency in research findings to find out what works and what doesn't work. So an example of this is categorizing people as adherent or non-adherent based on, for example, a self-reported tool. It's very crude, and it puts in this almost arbitrary cut point. So if you score an 8 versus a 9, you're non-adherent. And if you're a 10, you're adherent. It's too broad, it's too crude, and it also just serves to increase heterogeneity in meta-analysis and makes it very hard to compare different interventions. So if you're interested in this type of research, please don't dichotomize. More continuous measures are far more useful for meta-analysis. So where do we take this next? And I think this is where I'd really love your input on this. From our perspective, our research team, we noted that 71% of the interventions were multi-component interventions. So remember what I said, there was more than one behavior change technique. So more than one thing was happening in that intervention. But if more than one thing is happening, it's hard to know what's the driver of that. So what's the piece that's making the change happen? So it's difficult to untangle the black box of a complex intervention. It could be one thing so say you might have an intervention with 4 things, so goal setting, dose simplification, a bit of education, and electronic monitoring feedback. Which of those 4 is actually causing the better adherence, or is it a bit of all 4? It's very hard to tease that out, and that's, I suppose, the complexity of this type of research. And I think in order to improve it, or to know how to improve it, it's vital to first assess what's driving that behavior in terms of, what's the actual problem here? What's causing a person to not take their medications as prescribed? And I think to do that, the patient's perspective is crucial. That's really where the answers come from. And surprisingly, there's not a lot of qualitative research in this area to get the patient perspective on why they adhere or not. Again, when you're trying to assess non-adherence, we talked about unintentional versus intentional. It can be very difficult for a patient to disclose that they're choosing to not take their medications as prescribed for fear of judgment from their team, because, I speak for the situation in Ireland. We have a very high waiting list for transplants and not enough donors, either deceased or living. So to choose not to take your medication, there's always going to be some judgment, even if it's subconscious judgment on behalf of the team. And there may be very understandable reasons why you're not taking it, but it can be hard to disclose. And then trying to capture that in a research capacity, that gets very complex. And I also think an understudied area is pediatric and adolescent populations. There's very poor suppose, qualitative or more in-depth research to look at the reasons why they choose to not take their medications or unintentionally don't take medications. So I suppose I would like to hand it over to you in a way now, in terms of just to get your thoughts on those findings. And I suppose the three questions I'm very interested in, I know people on this call are from different backgrounds and work in different areas or have personal experience of taking these medications. So what's your real world experience with non-adherence post-transplant? What do you think would work to improve adherence? And what are your thoughts on measurements? So I talked about the very different ways to measure and that triangulation of taking all of the pieces of adherence to try and get an overall picture. What are your thoughts on what might work and what doesn't? Because I suppose our next step in this review, apart from updating it in 2 years' time, is to maybe try and untangle that black box piece and assess what works and what doesn't, and how could we pull that together and maybe come up with an effective way to both assess but also to intervene on non-adherence. So I'd love to get your thoughts on those three questions if we can. So I'm going to stop sharing my slides so that I can actually see you and also see your questions, because I can't see them at the moment. So I suppose just before I stop sharing, I did talk about the ABC taxonomy for defining adherence, and these are the two key papers when using that taxonomy. And I really do think it's the best way in measuring adherence to follow those criteria, because it's actually measuring the behavior itself, not the consequences of adherence. So when I talked about I can't say the word, measuring it properly, being able to look at the actual behaviors involved and not the consequences is really key in terms of those 5 steps. So in terms of having that transparency of measurement, the ABC taxonomy for me and for our team, we think it really is the best way, and it's supported in the literature. And I suppose just before I stop sharing, thank you for the invitation to be here to present these findings. And if you're interested or you're interested in this type of research and want to maybe explore this more, please do contact me, because I would love to share ideas with you, and that's my contact email there. So I'll go back to put those 3 questions in your mind, and I'll stop sharing now.